The EFIM was founded in 1996 and brought together the national societies of internal medicine from each of the European countries, both inside and outside the European Union. And the EFIM comprises 35 member societies representing over 40,000 internists. Our session today, that it will focus on preventive medicine and social determinants of health. And I know that this is timely and critical content, that we are all learning so much from each other. We're learning so much from the newspaper, and we're really learning it so quickly, having in many cases conversations that really are the conversations that we needed to have yesterday, but also that will be the foundation for the even better conversations that we have tomorrow, so that we can do our best for the patients, for each other, really for our communities, for the world. And so while we're here today, I will ask that attendees please mute your microphones and keep your cameras off throughout the presentation. But throughout the talk, we'll invite you to please consider utilizing the chat very robustly, because what we want this to be is a conversation, because we deserve to learn from you just as much as I know that I deserve to learn, and just like you do, from our wonderful presenters. So please do use that very robustly. Please consider, if you're on social media, to also join the conversation on Twitter, with thanks to Dr. Tiffany Leung, who will be tweeting from this and using the hashtag IM2021. Do know that the meeting is recorded, and also that the resources shared here during the meeting will be made available to everybody following the meeting. So with that, and it is my pleasure to introduce our speakers. You can see that Dr. Bornstein will be there's so much to say about her. She's presently a regent. She's a former governor of the Texas chapter of the American College of Physicians. She is the chair-elect of the Board of Regents. She has been the chair of the Health and Public Policy Committee, and also is the present chair for Diversity, Equity, Inclusion, and is widely recognized for her expertise in this area and more. And then also you'll see that also Dr. Nicola Montano, that he is the immediate past president of the European Federation of Internal Medicine. He is a professor of medicine at the University of Milan, and he is also someone who is widely published, has numerous funded grants, and he's also widely lauded. And we are so privileged today to have these really international experts to speak with us. So with that, what I'm going to do is turn it over to them. I'm going to mute myself, and I will ask that we move to the next slides.
Thank you very much, Eileen. It's a real pleasure and an honor for me to be here and participate at this American College of Physicians European Federation of Internal Medicine workshop. And so I would like to thank the ACP leadership and also the EFIM leadership for having selected me to talk in this meeting. So let's get into the topic of our talk. So if I should have to graphically design the determinants of health, I would use three circles: an inner circle in which I would draw personal environment, another circle in which I would write social environment, and an external circle in which I would put the natural environment. So as a physician, as an internist, we are usually focused on the personal environment. So all the characteristics that relates human beings to health and diseases. But above the personal environment, there is a social environment. And this is the topic that we are dealing with. And social determinants of health describes indeed the social, economic environment in which people live and work, and how this environment influence health and the quality of life. And in the last 20 years, there's been a broadening of the discussion about social determinants of health, from a simple, discussion between the link between poverty and health, to a more specific description of components that are related to the social determinants, and you can see here in this slide. So healthcare, both access and quality to the healthcare, the nature and of the neighborhood and the housing where we live, the social and the community context, the economic stability, education and access in terms of access and quality. So all this we are learning, and all these factors are becoming so important in determining our health and our disease, because all of this impact from a neurobiological point of view strongly with our life. You know, to talk about social determinants of health in terms of preventive medicine, we also have to touch some issue that goes upstream to the to the politicians. And so let me just briefly describe this case to you. This is a case that I had. Next, please. This is a case that I had a few years ago. I met a man. He was 23 years old, arrived to Milan from Morocco. 6 months before, he was an illegal migrant. He had been searching for jobs, sorry for the typos, without success, and he was living with some friends before in a small apartment, and then wherever it happened, in the cars, train stations, parks. And of course, he had irregular access to food and no access to housing at some point. So I remember on early February, went to a facility where I was volunteering with other physicians taking care of migrants, of illegal migrants. And he had fever and cough, and was defecated, and was visited and sent back with acetaminophen and symptomatic therapy. Then a few days after he came back, because the fever, the cough was becoming productive, very disturbing, and with a high fever. So we sent him to a chest X-ray facility, and the chest X-ray showed a TBC cover. So nothing to say. This is a migrant with the tuberculosis. But this is, in reality, is not a disease, a man with a disease. It's a political issue. And it's a political issue. Indeed, our, this very important political leader wrote a Twitter and wrote, "Unfortunately, tuberculosis has come back to Italy, and Italians pay the social and healthcare costs due to years of disaster and invasion without rules and controls." So, immediately a disease became an hallmark of destruction. So a social problem, a man that had not received anti-tuberculosis vaccine in his country, who moved to another country where he, of course, escaping from a difficult economic situation. But he arrived and he faced a lot of problems, and mostly he faced no access to healthcare, no access to housing, no access to care. So a social problem became an health problem. And so this is something that, of course, a lot of politicians have been playing with. We are facing in the last 10 years a real huge wave of migration from North of Africa and Middle East in all the south of Europe. So the problem exists, the integration of people exists, but the problem is that this is treated in the opposite way that it should be. Our future are kids. But what is the impact of being a kid, maybe from a migrant family, without housing, without access to food, or also not necessarily from migrants, but in a normal family, but deprived of what a kid should not be, deprived of parents, deprived of toys, deprived of school. If this is our future, the preventive medicine should be played at this time, at this stage. Work, and because we already know that there is a so-called zip code medicine. And if we look at, this is Baltimore, this is an old study, and this is the life expectancy in birth in Baltimore according to the different areas of the city. And you can see that from the green and more wealthy areas to the red and poorest one, there is a difference of 11 years. So if I was born in the green, I had an expectancy of 11 years more than if I was born in the red one, but I'm always the same one. Work is very important. This is the figure of the movie by Ken Loach. Ken Loach is an English director, very famous. He won a lot of awards, and this was the winner of the Palme d'Or of the Cannes Festival a few years ago. And this is a wonderful story of a worker, of a building company worker that, he was a temporary worker, and it happened that he had a myocardial infarction. And so he had to stay first in the hospital, then he was discharged, but he had to stay at home because the physician said that he was not ready to go back to work because their work was a quite heavy work. Unfortunately, the insurance, the social welfare insurance, was covering only for 2 months. Then he had to go back. But after 2 months, when he went to the physician to ask for, the certificate to go to work, the physician said, no, you are not, your heart is not still in the condition to work. And then he lost the job. And since he lost the job, he decided to take another one. And so he started working, but then another myocardial infarction died, and he died. And this is a movie, a wonderful movie. I cried a lot looking at this movie because it's both a romantic and it really describes the craziness of the bureaucracy that we have, at least in Europe, because this is not only in UK, but it happens also in other parts of Europe. So work is very important. And we know next that according to our work, we have an expectancy of life. So if I am a professional, I have complete different life expectancy than an unskilled manual or partly skilled manual worker. So education, the social environment, the family where we live determine how then we live, our health. And, during this pandemic, what we saw was really the strong link between aging and poverty. We took care of a lot of older people that were alone, without social support, with low money, living, in this big building alone and dying for the COVID without no one. And I really like to show you here the key messages. There's this very nice editorial published on BMJ last January, the COVID pandemic and the social determinants of health. And the key messages, the 5 strong messages are that the COVID has affected groups that face discrimination and historical injustices hardest. And so we need, the support system that should have been geared to respond to this crisis proved inadequate. And the post-COVID world must ensure equity, social justice, solidarity, and a shift in the balance of power and resources to people living in poverty and otherwise marginalized. And this is what's happening with the vaccination right now. We know if we will not able to get the whole globe, even the poorest country vaccinated, we will fail. So we will save all of us together, or we will fail together. And we need a more social medicine. There is no way that we continue to do what we do and continue to talk about preventive medicine without including the social care and the social attention to this. A famous poet, one of my favorite, not Italian poet, wrote that this is the way the world ends, not with a bang, but with a whimper. I wrote a lot of essays. No one exactly understands what this sentence is about. There are a lot of hypotheses. But what I would like to say is in my context, the end is not a nuclear explosion, but it's just a whimper, and the whimper is this one. Americans first, Italians first, Germans first, French first, Spanish first. This is exactly the opposite of what we needed. This is the end, because as I told you before, we can save all of us together, but we will destroy if we are apart. Thank you very much.
Thank you so much, Dr. Montano. And also, colleagues, I should note that although I just said doctor there, both Nick and also Sue had said that in general, that we'll be referring to each other by our first names. And one of the reasons for that is because we really want this to be a conversation, and we would like it to be a conversation with you too. So that was very deliberate, because of course we want to make sure that we have people's permission for that. And with that, thank you so much, Nick. There was so much that was in there. I added to the chat the BMJ article that you mentioned, and also did note that it looks like Dr. Kinder noted that the map of Baltimore that you presented was very similar to a lot of our social determinants of health. And I bet others will say something similar too. I found myself being struck by what could be the overlay and what are the lessons learned that we learned from John Snow and the Broad Street pump also too, because there's a lot of epi that's happening here. But with that, I'm really excited next to continue our learning and also then to introduce my dear friend who's going to be speaking next. Then Sue Bornstein, I'll turn it over to you. We'll mute myself. We'll turn off my camera and ask everybody to continue to think about the things that they're saying, because we're next going to, after Sue speaks, and we're going to have a little bit more of a podcast style where we're just talking, and that we have this be really a conversation, and their presentations are the frame for that. Thank you.
Thank you, Eileen. It's wonderful to be on this panel with you, my dear friend, and to have the opportunity to get to know Nick, who we've had a couple of planning calls, and I don't think any of us wanted the calls to end because we all just shared ideas, and it was really a stimulating, wonderful exchange. So, well, I want to start with a patient story as well. And this is not actually a picture of my patient, but it does depict the clinical syndrome that he presented with. His name was Miguel. I met Miguel when I was a fourth-year medical student doing a nephrology rotation in San Antonio. Miguel was 52. He was an undocumented Mexican immigrant who'd lived in San Antonio for about 15 years. He worked as a day laborer when work was available. He lived in a multi-generational rental home on the west side of San Antonio in a neighborhood that was known for its difficulty obtaining even basic city services, including running water, electricity, and sewage. And as a person who was undocumented, he had no health insurance. And thus he had no access to regular healthcare, and certainly no access to preventive healthcare. And in addition, unfortunately, he had low health literacy. So when my team got the call about Miguel from the emergency department, we were confronted by something none of us had ever seen. And in fact, Miguel was experiencing uremic frost, a cutaneous manifestation of uremia. And when questioned, he said, yes, he had been a little bit more tired than usual lately, and maybe his appetite wasn't as good as it had been. He certainly was not aware that his kidneys were not functioning properly, and was surprised to hear the news. His laboratory test confirmed the diagnosis with markedly elevated renal panel and potassium. He was admitted to the county hospital for emergent dialysis. Certainly, uremic frost is one of the indications for urgent dialysis, but all of us knew that Miguel being able to receive scheduled outpatient dialysis would be very difficult, if not impossible. And my rotation ended shortly thereafter, so I wasn't able to follow up, but we all feared that his life was soon going to be cut short by his advanced kidney disease. And I share this story to show that I think that the effects of the social determinants of health really are additive. The conditions in which we are born, live, work, and die, which Nick really did such a nice job presenting. I have come to believe that of all the social determinants of health that impact individuals and communities, I really believe that housing and neighborhoods, the so-called built environment that we live in, are among the most important, if not the most important. Unhealthy communities cannot attract grocery stores, and instead they become food deserts or food swamps. Exercise can be difficult or unsafe. Air can be toxic, and typically healthcare is certainly not readily available. So all these factors really are tied to where we live. And we also know that people that live in segregated neighborhoods have worse health outcomes than those that don't. Next slide, please. Well, this is one of those inconvenient truths that Dr. Fauci spoke about yesterday. Housing segregation in this country had its roots in slavery. And the official policy of segregation ended in the 1960s with the passage of the Fair Housing Act. But all of us know that its insidious effects linger far past that time until today. And it's also clear that no other ethnic group in U.S. history has endured the persistent residential isolation forced upon Black Americans. Now, having said that, we certainly acknowledge that other marginalized and historically excluded groups, such as Latinx, Indigenous, and Asian people, have also experienced similar segregation. And again, we also know that segregation is just unhealthy. It can constrain the practice of healthy behaviors, as I described a moment ago, and encourage unhealthy ones. Going to the corner store that has liquor and maybe sausage to eat or crackers or something like that. So the unhealthy behaviors are sort of built in. And as is, I think, pretty clear, segregation can adversely affect access to medical care and to high quality care. And the myth is that racial segregation comes from unintended consequences of economic forces. Well, that simply is not true. And unfortunately, we know that federal, state, and local governments really systematically imposed residential segregation. They probably didn't intend to do it or intend the consequences to be as dramatic as they are, but things like racial zoning, public housing. Think about public housing. Where does it exist? Well, frequently it is built in previously mixed communities, and then they become segregated. There's a history of subsidies for builders to create white-only suburbs. There are tax exemptions for institutions that enforce segregation. And yes, there has been support, tacit perhaps, for violent resistance to African Americans in white neighborhoods. And so that unfortunately is our legacy. And so all of us are familiar with the practice of redlining, which is denying mortgages and loans for otherwise creditworthy borrowers based really strictly on where they live and who they are. And that effectively demarcated geographic areas that were off limits for issuing loans. And this, I think, is a truly tragic, really, these statistics that almost 2/3 of the neighborhoods that were deemed hazardous, quote unquote, in the 1930s are still inhabited by mostly minority residents. And these cities do have a significantly greater economic inequality. Conversely, 91% of areas classified as best in the 1930s remain upper to middle class, and 85% are predominantly white. And here is a statistic that really should get your attention, and that is that households that are headed by college graduate Black, Hispanic, and multiracial Americans have lower rates of owning a home than white Americans with less than a high school diploma. So I think that we can see there is a very significant and really very shameful history that we must really redouble our efforts to change. Next slide, please. So what can we do? I've given a pretty grim outlook on the whole situation with built neighborhoods and housing, but there are things that can be done. And there's a wonderful organization called the HOPE Initiative, and it stands for Health Opportunity and Equity Initiative. It's part of the National Collaboration for Health Equity. And HOPE really does something quite unique, I think. It provides a data-driven starting point on the equity journey, provides a roadmap and actionable data to help national and state leaders chart a path for achieving equity and opportunity in health. And please do look at the QR code to learn more about the HOPE Initiative and how, in the unique way that it is addressing and really trying to move forward equity in our country. So thank you.
Thank you so much, Sue. There was so much in there, and it was really so robust. I hope that people who aren't yet also able to look at the chat would do so. And also, if you're in a position to do so, certainly not when you're driving, to please do feel welcome to point your smartphone's camera at this QR code, and then the slides that we just saw will be available to you for your future reference, and then also for really when you have questions, and that's where we're going to segue to next. And I hope that you continue to add your questions, your comments, your reflections to the chat, because we do have these remarkable experts with us. And maybe I'll start some of that right now. One of the things that I heard from, first I heard from Nick was that when he talked about that we need to talk to politicians. And he really talked about that. And I can see Sue nodding. And I would like to hear from both of you how someone who is joining our call today, who maybe is also working full-time, or they're just not even sure where to start, what is the way that you recommend that we start to talk with politicians?
So this is a good point. So because we have to set a strategy, but the fact is that, for instance, what we still, so far, the research on the social determinant of health has been focused on is a descriptional research, okay? So we describe that there is a relationship, there is an association, while there is no research so far on what the upstream decisions then have the fall down on the health of the citizen. So I think that we should try and we should start to collect data and to bring data to the politicians. I really think that without data, these will remain words. And so you may find, you know, the wiser man who can listen and maybe think that this is something to do, or you may find the other, you know, the compulsory polyshit and negationist that will never take this into account, because of course it does not rely on the power that he has to defend. So data, so we need data, because, you know, during this day while studying, I just realized that there are a lot of description, there are fantastic description and observations, what downstreams, but we don't have anything that, you know, is telling us that a particular kind of policy is determining a shift. Because in that, you know, if we are able to get those data, then we will be able to say that there is a correlation between a decision and an effect, so a causal relationship. And this for a politician is something that, you know, is becoming more sensitive. Because otherwise, I think that this is, so first of all, to create awareness within our community. For instance, in my small world, internal medicine, we decided in our clinical history now to collect a lot of, you know, specific social information to put in a database. Okay, so we will have data from our specific community. But then we have to, you know, if we are not able then to define a research strategy, I think it will be difficult. So data first, and then talk with the politicians.
Sue, what do you think?
I think what Nick said is absolutely true. And I think there's a universality to it. So it's probably true in Italy. It's also probably true here. And I think one of the things we can do, and I know, Eileen, you put them in the chat, really very proud that the American College of Physicians has taken such a strong stand on these issues. I think in 2015, we wrote a paper about addressing social determinants of health. And I don't usually pay attention to this, but I noticed the other day that it had been cited something like 350 times by other publications or other authors. And so I think we started in a sense there, but we have continued writing a series of papers that you put in most recently, actually last year and this year, about these very issues and in our achieving. Sorry, I just lost me. I saw it drop for a minute, but the better, how we can make our whole healthcare system better is a lot of it is in there, and it is about equity and the like. Now, it's true that as far as politicians, sometimes, at least in my experience, sometimes the economic argument has to be made. And I think, Nick, your story about the man that had the myocardial infarction and then had to go back to work, that's a powerful story. That's an incredibly powerful story. And so having said that, politicians generally tend to think politically what's beneficial to them or to hopefully their constituents. Stories are very powerful. So the kind of story that you told, I think, would get people's attention and say, this is a person that died essentially because he had to go back to work. And so I think facts are important, but stories are actually probably more important in some ways. So.
Thanks. Nick, did you have anything else that you wanted to comment to what Sue had said? Or because I have a couple other questions and we're seeing some more in the chat also too. Oh, that's okay. You don't have to read them. I can read them aloud if you want, because I know we'd love to hear your thoughts. Maybe while more questions are coming in, I'm going to reflect a little bit on what I heard from you and also what I got to learn from both of you during our preparation session. And specifically, one of the things that I heard Nick talk about was the idea, I believe it was about how social determinants of health play out, including along a single trolley line, and how, like in the United States, we often think about we are finally having these long overdue conversations about structures of racism, but then how it isn't solely about but how we have these opportunities to think even more broadly like that than that, and we really have a duty to do so. And I wonder if I could hear a little bit more from you about both the representation of the trolley line and how that showed us about how patients' lives are so different and how their health outcomes can be so different, but also what are the other ways that while we have these meaningful and long overdue conversations about racism, that we think about other forms of social determinants of health and intersectionality as well.
So, the question is complex. It's a complex question. So because I was just reading, so can you rephrase the last, because I was reading a comment on the chat that there was regarding Europe, but I would like to answer later. So Eileen, could you rephrase the
Sure, I'll be briefer, which is, I wonder if you could tell us again the story about the trolley line and about social determinants of health as they play out even along one trolley line, but then also how we think about social determinants of health very broadly, and we think about intersectionality, because in the US we talk a lot about racism right now, because we need to.
This is the trolley is, and this is also referred to the question that was posed in chat about Europe and the fact that in Europe the access to care is generally more universal than in US. So how does it figure into the social? So I would say that in a different scale, even in Europe, is absolutely the same. And this is because, in the social determinants, access to care and medical care quality is one of the determinants, but it's not the only one, as we saw. And so, of course, in Italy and most of Europe, there is, let's say, a sort of unlimited access to care and quality. But this is not enough. This is what's coming out. And it is, of course, as a different scale from you. For instance, here, in Italy, and there's a very nice city close to Milan, Turin, and they studied along a trolley line going from periphery to downtown, to downtown, the historical center, and they found that the life expectancy was exactly like in Baltimore. So we have the similar, the behavior, the dynamic is the same. We may have more access, but we know that access and quality of care are not the only determinants. There are all others. And here is the intersection with the social. So if I have an old man with dementia alone, this is a tragedy. This is a tragedy if he does not have a support, because of course he will have the access to the hospital, but then what I have to do? So I have to look for a nursing home outside, but of course there are only few slots for people who does not have an economic support by the family or by himself. So we are creating at that point nursing home with people alone and without any support. And this is a sort of segregation. Okay. So the fact that, after when there is this, this is maybe more in US, all the problem that we have with the retired people. So when you become a retired and you're not productive anymore, somehow, is the community that is the family and the community. And this maybe is the difference between Europe and at least some country in Europe, for sure the south of Europe. The community and the family is really sheltering these people. But this is less and less. This kind of attitude, we are losing this kind of attitude. So the social problem become, unemployment is becoming, most in the south of Italy or in the south of Europe, a huge problem, because think about the stress that you have, the chronic stress. You are obliged to live every day looking for a job if you don't, and if you are not able to look at, to search for. So think if you have a family, at least you have a myocardial infarction, at least. So all these factors have to be taken in line. And we have to align the social problem with the health problem. And maybe prevention, there is a very nice abstract recently published by a group of pediatricians here in Milan. They found that the generalized anxiety disorder in young kids less than 12 years were related to the surface of the house. They were segregated during lockdown.
That's very powerful. And I feel like everything that you just described there really speaks to that, really speaks to the reason why all of us are here. And then of course, also that you have so much expertise in this area as the director of the Department of Clinical Sciences and Community Health. We don't see a lot of that being combined together a lot in the United States. I know that Dr. Bornstein has also done a lot of work in this, and I loved how she had framed the work related to housing and about that every system is perfectly designed to get the outcome that we have right now. I know I just changed what Don Berwick had said, but Sue, would love to hear from you and what you thought about what Nick said and also the comments and the questions.
Sure. Well, so someone asked about the relationship between Black professionals or professionals of color and housing, and it's a very insidious relationship. And let me just kind of expand on that for a minute. And so we talk a lot about building wealth, right? How if you look at the average white family in this country versus the average family of color, there's a significant, very, very significant difference. And why is that? Well, one of the reasons is almost certainly that segregation, as we described, tends to keep people in communities. And those communities, the housing stock the value of the housing stock tends to be lower than in other communities. And so, we always talk about this, and this is, what asset does practically anybody have that's the most valuable? And it's their home, right? And so just that inequality right there is part, it's not that, by no means is it the whole thing, but it's part of how this problem plays out in terms of building wealth for African-American, Blacks, and Latinx and other communities. So it's sort of the more you dig, the more you learn, and the more you understand. Again, it's insidious in my opinion. It really needs to change.
One of the things that's been striking to me while I've been listening to both of you is how deliberate you are with the use of language. So I did hear you both just name things as racism. I did hear you name things as social determinants of health. I did hear you be very deliberate about that someone was an illegal migrant rather than referring to them to other pejorative terms. And then also hearing that people can say and that people can repeat. And I also heard talking about naming it as people being from marginalized and historically excluded groups, and that is so important. And I wonder if you could speak to the power of the language that we use in the different audiences, including with politicians, but also with our peers and our language, and when we give education, and how language can help shape how we can move this work forward. And maybe I'll ask, in this case, Sue to go first and then Nick next, just to shake things up.
Well, thank you. And, it's an evolving story, right? It is a constantly evolving story. And as a matter of fact, we recently spent through the Diversity, Equity, and Inclusion Committee, we spent which Eileen so capably chaired. And I had the great honor of following her. We had the opportunity to really take a deep dive into how we categorize, if you will, what categories we offer to our members to describe themselves. And this is actually the American Medical Association has done a pretty good job with this process. And as you can imagine, it's complex because for a couple of reasons, not everyone fits in a box, so to speak, to check off. And the social norms around things are changing. And that's a good thing. That's a very good thing. So we spent quite a bit of time really trying to understand the best way to have people describe themselves. And it's a work in progress. And the other thing, and Eileen, you and I have talked about this, is the whole use of the word pipeline to describe. So we talk about the pipeline for medical students, et cetera, et cetera. And I learned not too long ago that in fact, that terminology might be offensive to some indigenous people in this country because of the terrible things that pipelines can and have done to their communities. So perhaps the pathway is a better way to describe it. So again, I think it's a matter of we talk about cultural humility a lot. And I think it's a matter of keeping yourself open and also realizing when you have said something that perhaps wasn't appropriate in that situation and being open to learning about it, to learning a better way to do it. But I think all of us are learning. All of us are learners, right, throughout our whole life. But it's a process.
Yeah, thank you. Nick?
Yeah, I totally agree with Sue. It's a process. As you said, language shape, and it's is a continuous process coming from awareness to the respect and to the listening and the knowledge, of the others. Because the first we have to listen, and this is what I heard now from Sue. It's very nice, that they were talking and asked the people to define, looking for a relationship with their words, not with our words. Because,
exactly.
Because we sometimes define, we design boxes, and we want people get into the boxes, while we should use the approach that Sue just described, different. We have to listen and to define. It's like the word racism. Racism not only against a skin or just an ethnic group against another ethnic group, but even to say that someone comes first than someone else. This is a racist sentence. So we have also to say clearly and to define clearly what is offensive. And, okay, so I think it's a process in which we have to listen much more to the others. We have to really and to define after that we have, and not before, because otherwise our bias and our prejudices will get into these boxes.
There's so many nuggets of knowledge there. Thank you. And I do note that we have about 11 minutes left in this session, and that our panelists are going to be answering 2 additional questions that I'm going to be posing to them about what are our aspirational goals, but then also what are tactics, very practical tools that everyone here can take away. But before that, I'm going to ask if I think Dr. Bornstein can also reflect on one of the questions in the chat that had to do with a couple things. One of them is, what is the individual clinician's duty, and also what is the way that we structure very tactically in our clinical environment this work?
Thank you, and thanks, Tom Bledsoe. Great, Tom Bledsoe is online, and it's wonderful to see you. And you raised a wonderful question, and Ryan Meyer addressed it somewhat too. And I would point out to you that in the QR codes that we shared on my slides, the last slide is by a woman named Jennifer DeVoe, and I think Marianne knows her, and I think Tom Cooney knows her. She's from Oregon. She's a family medicine doc, and she has really a great presentation. And the title of the slide is, how can we use the new IT and data infrastructure to integrate social determinants data into healthcare settings and take action? So and I can't really describe it as well as you can see it, but so she says, and Ryan kind of alluded to this, some of this data is already known. So in the primary care office, there's what are called community vital signs data. So that's imported from public data, kind of geo-sourcing, US Census level, matched to patient address. So there's already a lot of data out there. So that's one aspect of it. And then you certainly have patient reported data. So there's sort of 2 streams there that are going into. At the point of care, obviously you're going to talk to that individual. Now, I think the challenge is, like with everything in the fee-for-service world that so many of us live in now, it's like, one more thing. Now I've got to ask people about, do they have food insecurity? Can they pay their rent, et cetera, et cetera. And I get that. I absolutely get that. It can be daunting. So to that, what's so important about that, in my opinion, is this idea of a medical neighborhood to really find collaboration with, whether it's local food bank or the YMCA or religious, cultural organizations, to have a network to people to refer to. So, and it should not necessarily be the physician that's doing that. So it's somebody on your staff that is skilled at that. It could be, a health coach. It could be really a lot of different people that have the skill to do that. So I think there's data out there. And again, I want to make it seem less daunting. But I also think that if this can happen, that we will all see our patients will be healthier. They will have better outcomes in the long run. So just, Tom and others, take a look at that last slide in my presentation that has the QR code. It's a really nice kind of paradigm about one way to approach it.
Wonderful, thanks. And I think that that's a really wonderful segue to our next question, which is, and with my reflection, that 2 last things. One of them was collaboration was something that I heard was a theme there. And then I also heard listening, and that was something that Nick was very explicit about too. So with that, I'm going to ask him to first start with what will be our aspirational goals that you would like to leave us with in advancing equity in preventive medicine and addressing social determinants of health. And I wonder, Nick, if you would go first, and then we'll hear from Sue, and as we start to head toward our home stretch.
Thank you very much, Eileen. So aspirational, the aspirational would be that, my aspirational would be really to integrate the social needs with the health needs of a person. This is and the aspirational is that, and the target are the politicians. The target are the stakeholder who decide, because, are upstream, not downstream, because, downstream, we can even do small specific intervention, but we need a systematic approach, because, we can work a little bit on one community, for instance, focusing on education, on focusing on work, on housing, but it will remain just a small drop in the ocean if it's not followed by something very strong. I always been amazed. I always been by the idea of advocacy that the American College of Physicians has in terms of really being the advocate of the patients, not only of the patient, also of the citizen, because we have to enlarge, the scenario. And since we are physicians, we have to take care of everything who is human, as Plauto, a Latin comedian wrote in the Swaggering Soldier. So I'm a man, and I have to take an interest. Everything who belongs to man is not foreign to me. This is what, this is my aspiration. My aspiration is to integrate really the social care with the health care and make decent doors for a new normal, because this pandemic really hits so badly and highlight all the failure that we have in the public health and in the access to care and in the social programs, that I think we cannot leave this as it was before. And so this is the aspirational. Then the second question was?
So the second question, actually, this is great. I wonder if actually, may I ask we're going to come back to you also too, and ask Dr. Bornstein to say her aspirations while you think about what are the specific tactics that you would like everybody here and the specific step you would like everybody to take to help advance this. And we're going to hear that from Dr. Bornstein too. Is that okay? Awesome, thanks. So think hard.
Well, I don't have to think that hard because for me, it's a very pragmatic thing. And again, I like Nick, really want to shout out to the American College of Physicians for its continuous, energetic, vocal advocacy for universal coverage. And I think about my patient. Miguel, who he did not have access to any kind of healthcare. And you could say, well, he's undocumented. You know what? My idealistic world says everyone in this country should have access to healthcare. And I know that is going to be controversial in some corners, but I don't know how we really move forward. I don't know how we move health equity forward if we can't at least provide some kind of some kind of basic, maybe it is, coverage, whether it's preventive care, and maybe Miguel wouldn't have ended up having end-stage renal disease and dying too young. So I think that's really important. I think we have to have coverage, and we have to have more primary care physicians. And again, people have talked about the medical neighborhood, the team. ACP advocates very strongly for the team. This is not something that physicians can do on our own, by no means, nor should we, in my opinion. There are other people in the team that are frankly probably better at doing some of these things than we are. And so thank you, Dr. Fincher. Undocumented people are human beings first and nothing less. Thank you, Dr. Fincher. Thank you for reinforcing my strong beliefs. I live in a state where there's about 6 million. Now, Tom Bledsoe, how many people are in Rhode Island? I'm teasing, but 6 million uninsured people. And you can just imagine what the cost of that is, and the human cost and the financial cost. So I really think we have to start with universal coverage.
Thank you.
I totally agree. Tactics. So nothing can done by one man or few men. So we have to share. So we have to create a group, physician, social workers, psychologists, health managers, because it's very important to also to calculate the costs of what, an intervention that is not done. And then let's start collecting data and to talk about this in our Congress, creating awareness. As soon as we will create data, we will use them.
I love it. Thank you. And I think that you're modeling that in your directorship, and also then Dr. Bornstein, a tactic.
Sure. Couple of things. I think we have to educate ourselves. And to me, it's a lifelong process. So we have to really become students of history. And even though, as I mentioned before, it can be a very inconvenient history and things that we really don't want to confront, but we need to confront if we're going to move forward. And, I want to give a shout out to lots of people on this call, but I think about George Abraham, who on Monday nights volunteers in a clinic in Boston or in Massachusetts for people that don't have healthcare access. And so get involved in your community, be part of the solution. And I know everybody on this meeting is, but I think educating oneself is really significant. And it isn't going to be pretty always, but that's how we move forward, in my opinion.
Thank you. There is so much richness and that is going on in the chat. There are so many things that I learned from both of you. I do know that there's still a lot of people on the call. I know that you may have other duties. We really are at time that this is to end. I will ask if you're able to stay. Is that okay? I know Sue and Nick, are you able to stay or do you have to go? I know that for Nick, you're many hours ahead. That's okay. All right. Then we'll continue the conversation. Maybe we'll go for another 10 minutes because you have so much there. And I am seeing if people have to leave, then I'll just thank you for your time. I do note that we see that something very tactical that is being suggested by Dr. Matthew is to remember that we can check out Hunger Free America and that it is the IM 2021 designated charity. And I do see that also Dr. Mishra is asking a really good question about how do we have enough time to adopt these great resources and implement them into the clinical work. So we're screening, but how do we make the time to be able to try to connect the patients to the resources in their community? And I wonder if both Nick and Sue, maybe we'll start with if Nick could talk about how that is being done in Italy and in other EFIM other practices and environments among our EFIM colleagues, and then ask Sue to try to address that as well. So Nick, how do we make the time clinically to try to address these social determinants of health?
The reason why I said that we have to create a group is that because, of course, we are, let's say, what we can do for instance, I work in the hospital, so I'm an hospitalist, compared to the American world. So what I can do there, and I see the last part. So I see the disease, the chronic disease, when it becomes a real problem. But what we can do there is start collecting the data. So we are and listen to the patient, listen to them, to create really a sort of, to interview them in order to listen to their real needs. What are the unmet needs of a man who is living alone, who has a diabetes and he has, reduction in his vision, and it's rely upon social services that are not really constant in helping him. So what are the needs? What are the social needs? So not only so I would like to have in my ward a social worker helping me in collecting this, because the time, as you said, the time is difficult. It's really short, and we cannot do anything. This is the reason why we need more people working to this kind of collection.
Wonderful. And I think last comment, Dr. Bornstein.
Well, I'm gonna do a little bit of a lateral here, and I shout out to Suja Matthew and to Molly Southworth and Tom Cooney too for their work in addressing hunger in this country. And I'm certainly no expert in it, but I read about it and I donate, and I want to be part of the solution. I guess it has a lot to do with what Tom Cooney raised, and that is the issue of income and wealth inequality and the effects of social determinants on health. And so, in my world, if this is the United States of America, for God's sakes, in 2021, my God, I mean, we can send a little rover thing to Mars and how many billion miles away, and we can be a helicopter, but we can't feed our kids. Come on, we cannot feed our kids. 1 in 5 kids goes to bed hungry in this country. That is absolutely unacceptable. So I do think the whole wealth thing plays into it. I think that we need to work on segregation. We need to get housing situation better. I've never been a believer in guaranteed or whatever income. I'm starting to believe that maybe that is the way, that is the one lever that we may have to really change this dynamic, because it's not going to change on its own. And I think the current administration has really sees that and sees that we've got to do something major. And so I think they're all tied in. The food thing, again, I think it's wonderful that there are food banks. During the pandemic, the beginning of it, I saw pictures of lines miles long of cars in Houston and food banks. It's like, why are Americans so close to hunger? And wealth is part of it. History is part of it. It's a lot to do, but having a conversation like this, I think as healthcare professionals who obviously care a great deal about this, I think it's a really good start. And I think it's a conversation we need to continue.
I think that that's a really wonderful segue that probably will allow people to take their egress, and maybe then I'll wrap things up into before just some quick comments about what you've said. I will note that I added to the chat something that I hope everybody who is remaining here can consider as a tactic, which is to think about how we are using considering race or ethnicity as biological constructs rather than social, and to evaluate those in our clinical algorithms. And I included an article to the New England Journal, because that will allow us all to do better very tactically, and it's something we can all do today. And I think that we can do these things today, like you're identifying, as we think about really the broader issues, because I heard you say collaborate, listen, data, act, come together for advocacy, and to speak to the politicians. That is what I learned from you. I know that there's even so much more. I will ask us to continue to have this conversation via social media in big ways, in small ways. And I think that that maybe then we'll wrap things up here. And I'll thank all of the attendees and also the wonderful ACP staff and the EFIM staff who make this possible. And then with our last thanks also to Dr. Tiffany Leung, who has done a masterful job with engaging all of us for the ongoing learning in Twitter, particularly at the hashtag IM2021. And I'll ask the staff also to add the link to the slides again to the chat.
Really enjoyed it. Thank you all.